So, so there are some drugs that are already approved, and talk a little bit about those. And if you could just kind of touch, it does seem to me that as we're understanding the human genome, and we've talked about this before, that you may find that a drug that's good for renal carcinoma might really work on someone with CLL who's got a specific pathway turned on or turned off, but those are off-label uses, and I don't want to get you in any trouble talking about off-label uses, but in oncology there's a lot of off-label uses. Talk to me about what's going on there.
What is the current rage in oncology is that we now have the capacity to sequence your entire genome, and to do so within a fortnight at a cost that is considerably less than what had been in the past. And that allows you to analyze the genes of the cancer and analyze your genes that you inherit from your parents and say, what is the difference between these? And oftentimes you can pinpoint mutations in the cancer, and some of these encode for enzymes that might be either faulty or dysregulated or dysfunctional. And that gives rise to what may be called targeted therapy or personalized medicine for cancer. I would say this is taking off like a wildfire for treatment of cancers in general. And the idea has come about that if you have lung cancer, you might find a mutation in an enzyme that you find also in kidney cancer, or in breast cancer, or in skin cancer like melanoma. One example is the BRAF mutation, which you can find in hairy cell leukemia, and in melanoma, and in lung cancer. And there are drugs that can inhibit that enzyme that are effective in all these different types of cancers. So it gives rise to a lot of excitement that by finding out the genetic basis for the cancer, we may be able to intervene in a much more intelligent way and strike at the heart of what is driving that cancer in the first place. Now, with CLL, we have a different story in that the enzyme that are inhibited in CLL are not mutated. They are the same as what you inherited from your parents, and they have no evidence for any alteration. There may be alterations in how they are expressed, and that gets into a very complicated picture because you have to talk about how the genes are regulated.
The epigenetics.
Epigenetics, which is sort of like, if you think about it, the genes that you have in your brain are the same that you have in your big toe. And I would probably say that there's quite a bit of difference, but they have the same genetic makeup. And the only way they are different is by the epigenetics, how those genes are regulated. Well, the cancers do the same thing. So we have to understand how those genes are regulated. But here's the deal. In CLL, by understanding the biology, by understanding what might be considered the Achilles heel of this disease, it probably goes back to the nature of the B cell itself. We make 100 million B cells every day. And of course, if we kept those around, we'd be as big as this room after several years. So these B cells are undergoing tremendous turnover. They're grist for the mill. And they're genetically programmed to undergo cell death if they don't receive the right signals. It's sort of like a kind of a fine network of passwords, and they have to go through a rite of passage. And if they don't fit, then the cell undergoes cell death. So what we're finding out, though, is we understand those pathways for a cell like a B cell. By just intervening enough with those pathways, a tumor may become addicted to a certain pathway, and that cell becomes more sensitive than the normal cells in the body. So in that sense, can we learn about the signaling pathways? And sure, I mean, we've looked at that with the signaling pathways for the B cell receptor and also these chemokine receptors that allow for homing to the lymph nodes. And we're looking at drugs that are approved for other cancers and asking the question, will they have activity in inhibiting those pathways? And one example is a drug sorafenib, which has been used for renal cancer. It's been used in thousands of patients. And it has striking activity against the leukemia cell. And so we are actually looking at this in clinical studies. And interestingly enough, when we looked at the early clinical trials with sorafenib, they tried it in a whole slew of different tumors, but they stopped it in lymphoma and CLL because it caused the white count to go up, which is what we see now with a lot of these kinase inhibitors for either BTK or PI3 kinase.
So Obviously exciting. Doesn't work for everyone, though. Is there anything that we know about who these will work for, who they won't work for? Are we getting to that point where you're talking about personalized medicine, you can say, for this patient, I want to do this. Like, I'm thinking, okay, if you're ZAP70 positive, maybe that's now a good thing instead of a bad thing. Maybe a BCR, blocker will work better if you've got that pathway turned on. Are we at that point yet?
Yes, I've always said that when patients are told they have bad disease, it means that they have bad therapies for their disease. It doesn't mean they have bad disease. And so, in a sense, having ZAP70, of course, accelerates things. It makes the B-cell receptor more responsive, and so it puts the leukemia in higher gear. But that makes it more susceptible, too. And one thing that we're learning is that there may be situations where the more aggressive the tumor, the more addicted they become to these pathways. And I like to liken it like the schoolyard bully. You know, he's really ferocious, but if you get at what is his weakness, then you can actually tear him down and he becomes a wimp. And that's what we'd like to do with these cancers. So the more aggressive cancers, of course, they may be more sensitive, and there are data to support that notion. So cancers that may be more aggressive, ones that particularly patients who have bulky lymph nodes, these patients may be responding better to these agents than patients who have more indolent disease characteristics. However, I think that we could still understand ways to treat all comers and to find out what patients might be best suited for these drugs, or whether we can start to employ combinations of these drugs. I'm very excited about the work on some of the newer monoclonal antibodies, which have really been a game changer for the treatment. I could safely say that monoclonal antibodies are the reason that patients are living longer.
We're talking rituximab and the new generations of
and the new generation of antibodies. Ofatumumab is the second generation. Now the newest kid on the block is GA101 or openlatuzumab, and this drug, I like to say it's like rituximab with an attitude. And so we've had very striking responses to date, and that's in clinical trials right now. So coupled with antibodies are being able to maybe use an inhibitor, and when it wears down and cells learn a way around the inhibitor, you might be able to use another inhibitor or a BCL2 antagonist or an antibody. And I think all collectively we might be able to do a 1-2 punch on this disease that if it can't eradicate it, it could make it a chronic disease that can be managed for many, many years.
I got to ask you about CAR-T and where that is. To me, it seems like we're just way too early in the game, but I'd like your opinion on that.
Well, I think it's a very exciting technology, and what you're referring to is chimeric antigen receptors, which is CAR, and the T cell. And so what the strategy is that you have the T cells removed from the blood of the patient, and then those are altered. You introduce a gene that encodes a receptor that's a chimeric receptor. Part of the receptor binds to the proteins on the tumor cell, and then the other part of the receptor are signaling molecules that the T cell ordinarily would use to get it activated, to make it grow, and to become actively cytolytic, or to kill the tumor cell. And so it confuses the T cell. The T cell can home specifically to the target, gets activated to grow, and can go after the target and kill it with a great deal of specificity. There's a lot of excitement about this. The work done at University of Pennsylvania with the CARs that were directed against CD19, with improvements in how you make that chimeric receptor, these T cells are living longer and being more active. And so in a few of the patients that have been treated with this approach have eradicated all traces of CLL. Unfortunately, because the protein that they're going after is present on all B cells, they don't have any B cells. And so we have to contend with that. I mean, B cells have an important role in our immunity against the outside world. So these patients are really critically dependent on infusions of intravenous immunoglobulins, and they have practically very low, negligible levels of IgM and IgA, which you can't get with infusions of IVIG, which is primarily IgG. So I still have to work out some of these details. Would I recommend people jumping into that? Well, I think that it's a challenge because the early infusion of the T cells made the patients quite sick. There was tumor lysis. The patients had an extended stay in the hospital. And I think that you know, this has to be something that may be borne in mind in terms of how to do this best. I'm very encouraged, though. We're working on a protein that we found on the leukemia cell that doesn't appear to be on normal immune cells, B cells and T cells. And we're very excited about, we've generated some receptors that might bind to that protein called ROR1. And we recently presented some of that work before the Recombinant Activities Committee, and they've given us the green light to go forward in developing a clinical trial. And this may be quite exciting because if we get, again, a protein that's specific for the leukemia, and you get the T cells armed and ready to gun down those cells, my hope is with this type of therapy, we might do the 1-2-3 punch and really eradicate this disease and allow patients to maybe be free of having to take any medications, which would be marvelous, I think.
Pause for a sec.